So is pain with sex often connected to pelvic floor tension?
It can be one of the many different possibilities, yeah. So if someone has a lot of pelvic floor tension, remember we were talking about, I'm very visual as you can tell, when we were talking about the pelvic floor, where if it should be like this most of the time, if you have a pelvic floor that's like this, and now you're trying to have something going in there, you're already starting with so much tension that is absolutely one reason for pelvic pain. Now, what can happen is it can be a secondary problem, meaning if someone had a surgery, a childbirth happen, or any kind of other thing that caused the bladder pain, for example, chronic UTIs, over time they can cause the pelvic floor to go into a spasm. So they may not have had a pelvic floor problem to begin with, but over time, if they had another issue, the pelvic floor starts to get into a guarding pattern, and then it can become an issue.
So what other techniques would you use for down training of the pelvic floor?
Do you mean what I would do with patients, like what it looks like, or more what they can do at home? Or
I would love to hear what you do with your patient.
All right, you just want to see me do more visual things, right?
Yeah.
Okay. So, all right. So let's pretend you've got these muscles all around here. There's many muscles. Okay, we have superficial muscles. We have a second layer around the urethra, and then we have deeper muscles. Most of us, when we talk about pelvic floor exercises or Kegels, we're talking about the deep muscles back here called the levator ani group, but there's actually many muscles. I mean, there's about 20 muscles that make up this whole region. So what we first want to figure out is it tightness around here, the bulbocavernosus, superficial transverse perineum. There's many different muscles around here. If it's deeper, what I actually do, and again, this may seem graphic, but this is welcome to my world, is we actually have them, there's different techniques you can do. We can just do like a stretch. We can have them do a stretch at home with certain things too, but we basically take it and we can just stretch a muscle and see if they respond to that over time. What we're trying to do is, again, it's working at a neural level. We're saying this is where your muscle should be. Let's hold it for a little bit and then relax. Let's try that again, and then over time see if that just becomes more relaxed. Sometimes some people do trigger point release where they actually hold it for 90 seconds. That's not my preferred mode of action, but some do that. So you can do a trigger point release. You can do a static stretch. You can do, what I love to do is just like you would do in the fitness world, reciprocal inhibition with the hamstring, for example, where you actually have them contract a little bit. They contract the muscle, and then when they relax, you then use that and help further stretch that muscle. Some patients actually are so tight that they need some sort of aid, so they may benefit from getting a muscle relaxer as well. Sometimes a local vaginal Valium suppository, or an oral type of muscle relaxer, but again, depends on breastfeeding and so many other issues. But some people do need additional help, just not therapy, but they actually may need medicine to help with that as well. So essentially, I'm doing a lot of different techniques to lengthen the muscles, because remember, if they're tight, they're pulled in. So we're trying to see if we can lengthen and stretch the muscles so that they can function better again. So those are the manual techniques I would do. And then certain stretches, a lot of people don't know this, but the adductors that are coming onto the pubic bone, the adductors, when they fire, so when you have your adductors firing, it actually fires into the pelvic floor. The transversus abdominis, when that fires, it fires into the pelvic floor as well. So I want to sometimes do manual treatments to stretch out and provide myofascial work to transversus abdominis, adductors that are attaching here, any of the muscles that are also attaching in and around the pelvic floor. Another big muscle is the obturator internus, is a hip external rotator. So we'll sometimes go inside and get the obturator internus, or we can do stretching to the hips, because improving hip range of motion will help the pelvic floor as well. So it's looking at the local system, but then also looking at the larger system, which brings me to my I can't say my final prop because I may have other props, but my chicken prop. And I don't know if anyone's seen me or seen this chicken prop. The reason I use it is because this whole area is basically it's pressure system. Okay, so you're probably wondering still, why do I have a chicken? So if someone has too much pressure and they're doing a Valsalva and they're pressuring down, in the worst case, you're having this type of thing happen where there's a pressure system issue and you've got prolapse coming down and out. So I use this chicken a lot to show that you've got the core is made up of transversus abdominis, the pelvic floor, multifidus muscles in the back, and your diaphragm. And so you can't just treat the pelvic floor. If someone has a leaking problem or a prolapse problem, you can't just put them on an exercise program and hope it helps. You want to look at, are they tight? Is there a problem around their diaphragm? Are they strong in their back? Are they able to contract nicely around the transverse abdominis? Does the pelvic floor lift nicely? So we're looking at the whole system. So when I treat someone for issues at the pelvic floor, we're also, if you're doing a really good job, you're really looking at all the other aspects as well.